Uh, Good morning, everyone. Happy Holi to all of you. Today, we will be discussing about the uh, method to achieve ideal balancing in total knee replacement. We all know that previously, before the era of robotic joint replacement, the knee replacement was mainly about the soft tissue release and soft tissue surgery. But recent changing times, the concept has been changed. We want to achieve ideal balance without handling much of a soft tissue. We are going to do a bony cuts in a method that we achieve a proper balancing of the knee joint and keeping in mind the axis of the knee joint, that is hip knee axis should be in a neutral alignment, that is around 180-degree alignment. Okay, so without wasting much time, we'll get into balancing of the knee joint. We have to achieve a proper balance in the complete 0 degree and at 90-degree flexion. Ideally, we have to have a proper balance throughout the range of motion. We check mainly in complete extension and complete flexion at 90-degree flexion. Ideal balance should be equal, and we expect a gap of around 9 millimeter for the medial joint and lateral joint. Ideally, it should be 7 to 9 millimeter gap on the medial side and the lateral side. We check the once we have started the surgery, initially we check the gap in complete extension and complete flexion. We assess the gap at lateral side and medial side. Most common deformity which we correct is varus knee. Most of the times, once we start the surgery in the varus knee, we find out that the medial side of the joint is very much reduced gap, and lateral it is almost normal gap. So once we check the extension gap and flexion gap, we come to see the abnormalities of the balancing. Most of the times in the varus knee, I talk about the varus knee today, and most of the times in varus knee there will be a extension gap in which the medial side the gap is very much less. There will be hardly 1 millimeter or 2 millimeter gap available, and lateral side maybe around 4 millimeter, 6 or 7 or 8 sometimes. That is a possibility. So we have to adjust the positioning of the femur or tibial implants in such a way, or tibial or femoral cuts in such a way with that we get a equal balance on the medial side and on the lateral side in both extension and in flexion. So what all the options we get? We can adjust the tibial cuts or femoral cuts. Inside the tibial cut, we can either increase the cut or decrease the cut, or increase the angulation of the cut, either in the varus cut or valgus cut. So in tibial implant, if we increase the cut or decrease the cut, it is going to affect the balance in both extension and flexion. Both the extension gap and flexion gap are both affected equally, and medial and lateral gap are affected equally. So supposedly the joint is tight in both extension and flexion, we can increase the tibial cut size by 1 mm, 2 mm, but we have to know that it is going to affect both lateral and medial gap equally. Okay, and second thing we can do with the tibia is either the varus cut or valgus cut. So varus or valgus cut is going to affect the gap differentially. It is going to affect both extension gap and flexion gap, but differentially. Supposedly we are going to increase the tibial cut in the varus more, then definitely medial gap is going to increase. But we have to keep in mind that along with the gap changes, it is going to affect the HKA axis. So we cannot, according to scientifically, we cannot afford to have more than 3 degree of varus. Nowadays we say that even up to 4 degrees okay, but in my personal cases, I never go beyond 3 degree of tibial varus. So if supposedly in a varus knee there is a medial gap is very tight, we can increase the varus of the tibia by 1 or 2 degree to achieve an increased gap on the medial side, so that gap balancing is. One more adjustment we can do in a tibial implant is increasing the flexion or extension. So changing the flexion or extension of the implant is going to affect the extension and flexion gap differentially. Supposedly we are flexing the tibial implant more, that means it is going to increase the flexion gap more, and it is going to reduce the extension gap. So supposedly the knee is more tight in the extension and less tight in the flexion. We can increase the extension of the tibial implant to some degree, but we have to be mindful that the flexion or extension of the tibial cut is going to affect the final flexion deformity or hyperextension deformity. And also we have to be mindful that the keel of the implant might be touching the anterior or posterior cortex, which you should be mindful and adjust accordingly. The adjustments that can be made in the femoral implant are we can shift the femoral implant, either it is proximal shift or distal shift, or we can shift the implant in the anterior and posterior side, like anterior shift or posterior shift. So in shifting, supposedly we are shifting the femoral cut proximally, we are going to affect the extension gap only. The proximal or distal shift is going to affect the extension gap, and it is going to affect the gap equally on medial and lateral. Supposedly we are increasing the proximal shift of the femoral cut, distal femoral cut by 1 millimeter. That means we are going to increase the extension gap, but it is not going to affect the flexion gap. At the same time, it is going to increase the extension gap medially and laterally in the equal amount. And supposedly we are shifting the femoral implant anteriorly or posteriorly, we are affecting only the flexion gap, we are not affecting the extension gap, and the flexion gap is going to be affected equally on the medially and lateral side. So we have to be mindful about the femoral notching. If at all we are shifting the femoral implant more posteriorly, there is a possibility that you are notching the femur. So you have to be mindful about that one and be careful while doing the cuts. And one more adjustment we can do with the femoral implant is rotation. It could be varus rotation, valgus rotation, external rotation, internal rotation. So varus and valgus are going to affect only the extension gap, and there will be a differential effect on medial and lateral. Supposedly I am increasing the varus at the femoral implant, then it is going to increase the lateral gap, decrease the medial gap only in the extension. One more change we can do is rotation. We can do external rotation or internal rotation. So supposedly I am increasing the femoral external rotation, then I am affecting only the flexion gap but differentially on medial and lateral side. Supposedly I am doing increasing external rotation, I am affecting the flexion gap in such a way that I am increasing the medial gap in flexion. So supposedly my inner varus knee, I have achieved the extension gap equally, but in flexion there is a medial side tightness. I can increase the femoral rotation, but you have to be mindful that the rotation of the implant is going to affect the patellar tracking. So much of internal rotation might cause a patellar maltracking leading to patellofemoral